know, we'll
Party
just go
time.
by.
Party time.
Party time. So let's go ahead and get started with introductions. So we will just go around the rooms. I know that we have a few new faces, but let's go ahead and get started with them on. Do you mind kicking us off?
Not at all. Hi, I'm Yvonne Derrison. I serve on this board and I work for St. Charles.
My name is Rich Levin, and I'm the CEO of Best Care Treatment Services, and I'm your behavioral health representative.
Hi, good afternoon. It's Patty Adair, Deschutes County Commissioner. It's such a pleasure to be with this group. Thank you for reconvening in person.
Absolutely.
I appreciate it.
Yes.
Megan Hayes with Elizabeth Medical and I'm the CEO.
Wonderful. Nice to see you. Tammy Bainey, Executive Director of COIC, and your tour guide for today's meeting.
I'm your co-captain
Yes.
here, Carmen Madrid with Central Oregon Health Council Executive Director.
I'm Justin Civil, I work for Summit Medical Group.
Liz Johnson, community member on the board.
Dan Stevens with Pacific Source. I am the CCO representative.
Ooh, nice to see you in person. Yeah.
Michaela Arsenault, project manager at the Health Council. My pronouns are she, her, and hers.
Gwen Jones, project manager, she, her, hers as well.
Kat Mastrangelo, excuse me, volunteers in medicine, she, hers.
I'm Mike Shercliffe, ex-CEO of Danny Dillon, board member for the Health Council, and supposed to be retired.
Yes, well, we're excited that it's turning out in this way.
We were just talking, I'm here in person because I'm so tired of being isolated. It's just really nice to see all you people. And I've been sitting here next to a lady from Grain, Oregon. She knows where Grain is, and I know where Grain is. So not only that, we both know Vera Brown really well. We're on center having a conversation with a good life person.
And
We're bonded.
Yeah, she's a good one, and that too, yeah, yes.
Hello, everyone. Katie Plum. I'm the public health director in Clark County.
I'm Erin Fair-Taylor. I'm the Vice President of Medicaid Programs at Pacific Source. Hello, everyone. Tricia Wilder. I'm the CCO Director for Central Oregon. I use SHEEP programs.
Hi, Leslie Niegebauer. This is funny.
Senior Director of Medicaid Governance at Pacific Source.
Hi, everybody. Lori Hill, CEO, co-pilot.
Wonderful. Rebecca.
Hi, everyone. Rebecca Berry, Grants and Metrics Manager, SHEEP programs, Oregon Health Council.
Ruby.
I'm Camille Smith, also with the Central Oregon Health Council.
Kelly Adams. Great to see you. And virtual. Brad, we don't have our feet up on your desk quite yet, but would you like to introduce yourself?
Yeah, Brad Porterfield, Executive Director, Latino Community Association, also consumer rep and chair of the Community Advisory Council.
Wonderful. And how about Renee Worth, please?
Hi, everyone. Renee Worth, Central Oregon Health Council. My pronouns are she, her, and hers.
Excellent. And how about Elizabeth? We can welcome Elizabeth here in just a moment. How about Dustin?
Hi, everyone. Dustin Zimmerman, your innovator agent with the Oregon Health Authority.
Excellent. And Jeff?
Hi there, I'm Jeff Davis, CCO Medical Director in Central Oregon for Pacific Source.
Wonderful. Divya?
Hi, Divya Sharma, Chief Medical Officer for Central Oregon IPA, representing primary care on the board.
Wonderful. And Divya, can you hear us okay?
Yes.
Okay, groovy. All right, have I missed anyone on the video? Okay, and Elizabeth, if you can hear us, but just maybe it's not the right time, then go ahead and just introduce yourself when you feel like there's a we did a break. We'd love to hear from you. Okay, so for today's agenda, we've gone through with the welcome. We do have one change to the agenda, and that is the discussion on the regional housing who's on first. That is going to be moved to our meeting in October. So it is not quite ready, prepped for prime time, and so we'll be giving you the gift and we'll get more time back. Are there any other changes to the agenda for today? Okay, so next is public comment. Is there any comment from the public or anyone who wants to share anything or anything to bring forward for the council? Okay, hearing forward to the consent agenda. Is there anything on the consent agenda that we want to change? The board minutes, any edits, additions, any changes? If not, I would welcome the motion.
Adoption.
Okay, second. Wonderful. Any further discussion? All those in favor?
Aye.
Okay, see some hands on the screen as well. Anyone opposed? All right. Moving on to announcements. Do we have anything that we want to bring forward?
I'll bring something forward. I just want to recognize Camille Smith for always setting this table together, and also her recent promotion as executives, not executive. Sorry. Reasons for everyone. Executive assistants and operations. She has been doing a lot of the heavy lifting in our IT transition, and really is the funnel for a lot of the things that happens along with the rest of the staff that puts this board together. So just wanted to recognize that. And I think there's a duck race that's happening this weekend, isn't there?
Yes, Rotary's annual duck race that will benefit more nonprofits.
Excellent. Are there still duck tickets available?
There are still duck tickets.
Okay, not to.
So you can actually buy them on the day of.
Oh, wow.
And if
Okay.
you haven't seen the ducks go down the stream, it's a pretty cool thing.
Okay.
They have the dump trucks, dump the ducks in the park, they go down the river into the little slot, and first 20 gets free prizes.
And I know Latino Fest is happening this Saturday, and then Megan has a party too.
Yeah.
Okay, well, let's talk about your party first. So what would you like us to know?
It's our 20th anniversary for Mosaic, and there's a community party in Benton Music Hall. Open to everybody.
Okay,
5:30 p.m.
okay. That would be great. Yeah, do you mind if you, that would be wonderful. Okay,
Is that the 23rd?
right.
So the Trinity will be great.
Oh, fun. Okay, that'd be great.
It's a great venue.
And Brad, do you want to talk a bit about Latino Fest?
Yeah, thanks. And I also want to let you know that we can hear you guys pretty well, but it helps when you face the screen. As near as I can tell, that's the biggest difference maker. Because Megan, we could barely hear you when you were looking at Tammy. So I know it's unnatural not to look at the person you're talking to. So yeah, we actually have, first I want to mention Welcoming Week. So the city of Bend is a welcoming city, official member of Welcoming America, as is Latino Community Association. And Welcoming Week starts tomorrow. It's an annual week of events that several different community organizations participate in, providing activities for the community. And tomorrow is the kickoff, and we are hosting the kickoff right there where you're sitting from 5 to 8 tomorrow, right there in our Family Empowerment Center. So I hope people can come, and I hope that you will invite folks from the community, especially our immigrant and refugee neighbors. So please come 5 to 8 tomorrow, right there where you're sitting. And then, yeah, Latino Fest is Saturday in Madras from 11 in the morning to 5 in the afternoon. So we're very excited to bring that back after 2 years of pandemic pause. So yeah, please bring the family. Both events are free and open to the public.
Excellent. Any questions on any of that? Any other announcements?
I do have an announcement as well.
Yes.
I would like to announce and then celebrate the Central Oregon CCO is 10 years old. People who are here in person, we're going to start with the staff.
Does that make us 4th or 5th grade?
Right. They're mini, so you can have one.
For 10 years.
Yeah. 10 years old. I also have gluten-free that I'll pass around that is labeled gluten-free.
Wonderful.
Happy 10th anniversary.
Yay! Wow. Does it feel longer at all to anyone else? I mean, right, it's that. I know, I feel like it's sort of that. It's, we have come a long way. I want to just recognize lot of twists and turns. And if we think about where we had anticipated that we might land and where we actually landed, I feel really good about the place that Central Oregon has positioned the state of Oregon in being able to achieve some incredible successes for those that we're serving. So it hasn't been without challenges, and there certainly are challenges in front of us, but we weren't sure if we were going to be a regional health board or a accountable care organization we had a number of iterations. And to be able to play a part in systems change in an entire state is something alongside people that I not only care about but enjoy being with. I don't think you get an opportunity to do that every day. So just wanted to say thank you for being on this journey and allowing me to be on the journey with all of you too. But I just would say, what a wonderful day. So thank you for celebrating 10 years. Yes, really cool. Rick, I know you have a comment or two, I can tell.
I just remembered that there was an original white paper that we did.
Yes.
And my wife still calls this the white papers thing.
There was also literally a napkin on which we drew the governance model and the JMA, even though it wasn't called that yet.
Yeah.
And the state said, no, that makes no sense at all. And it did. We had to go meet with Bruce Goldberg like 3 or 4 times. And then when they finally figured out what we were trying to do, I think they came out and observed a couple times.
Can we be
And
on
then they
that?
ultimately, right. And then when we became a CCO, a true CCO, I think they said, okay, now we don't be on it anymore. But they initially said, we can't point to the single point of accountability here. You've obfuscated. It's like, no, this is more accountable. So, and then 3 or 4 months later, they started like.
Yeah. And wanted to be invited to the
almost
dance.
failed the first
Yeah,
round of first
right.
test.
Right.
Well, and we started forming this, Megan and Dan were there at meetings regularly at Stage View, which was a little like.
Of all the locations.
Yeah, of all the locations. We were mad at the conference room at Stage View for a while. Plotting and planning. I'm not sure all the CEOs understood what we were doing, but
Well done. And thank you for the cupcake. Okay, any other announcements? All right, I'm going to turn it over to Rebecca. We have the regional health assessment, the community survey update.
Trying to figure out where I'm standing for this.
Do you maybe want to
May
just
I,
sure.
may I be
Yes, you
It's
sure
on that screen.
can. Yes.
Thank you, Glenn. Folks online, let me know if you can't hear me. I'll try to be loud. So just wanted to share a little bit about the Central Oregon Community Health Survey. Next slide, please, Glenn. So we launched this health survey in June of 2022. It is a continuously collected survey, and we're continuously collecting this information through December of 2025 at this point. It's open to any person in Central Oregon, Crook, Deschutes, Jefferson, the Confederated Tribes of Warm Springs, and Northern Klamath counties. So that geographic area of Central Oregon. The financial partners in the survey are St. Charles Health System and the Central Oregon Health Council. So we're splitting the cost of the dissemination of this survey. Results will be used to inform the 2024 regional health assessment and St. Charles's next community health needs assessment. We hope that the results will also inform a lot of other assessments such as Mosaic. So data will be provided publicly on the Central Oregon Health Data site. It'll be updated on a 6-month cycle. If people want to see that data through a different lens than what we've provided on the site, we can work with you to get that information. Next slide, please, Glenn. Survey results will also help define the priorities for the 2025 to 2027
lot different than how we've done it in the past. In the past, we've kind of gathered quantitative data, gathered information from focus groups, prioritized based on our ability to actually make a difference in the topic area, how much it would cost, how many people would be impacted. This time, we're really reaching out to community members and asking them what is important to them, what are they seeing as needs for their loved ones and themselves, but also for the community within which they live. So demographic data. So we can look at the data in this survey through all of these different lenses. We can look at it by income level, disability, the county in which somebody lives, their ethnicity, assigned sex, veteran status, sexual orientation, household size, race, age, zip code, gender identity, education, and language. Survey topics include top household health concerns, what would most improve community health? So asking folks in your community, what are the top things that would most improve the health of your community? We ask questions around discrimination, health insurance and barriers to healthcare, employment, education, housing, transportation, safety, food, community resources, child access to healthcare and childcare, and there are COVID questions. As you can see, it's a long survey. It takes about 15 to 20 minutes to complete. At this point, we've had about 800 people complete the survey. And we have some gaps that we're realizing. So some of those gaps are, we're not getting, when we look at the demographics of our region, we're low in Crook and Jefferson County responses.
It's not my fault. Folks,
I'll look somewhere else next time. I know, only for the gaps. I'll look at the ceiling. High school education or less. So folks who have only received a high school education or less than that. We would like to see some more survey responses from them. Hispanic, Black, 18 to 34-year-olds. We're missing that younger age group. Folks who are houseless. Spanish as the primary language. Single person households. We're a little low on there. And households of 5 or more. Household incomes making $35,000 or less. Veterans and males. For some reason, males do not want to complete our survey. I'm looking at you, Rick.
I'm filling out the survey.
So I'm just kind of sharing this as you kind of ponder, some populations you might know that might want to take this survey. We offer the survey in paper format. We would prefer that it be actually completed online. It's just a little easier. It's available in English and Spanish. Top 3 concerns at this point, going back to those survey topics. So if we ask the top 3 concerns for you and your household, and again, these are only the first 800 folks that have completed this, but what we're seeing overwhelmingly is access to affordable healthcare services such as doctors available nearby, wait times, services available nearby, do they take insurance, and other things. We haven't dived into the qualitative data, so we asked them to comment and share more, and there are so many comments. So we're going to dive into that and really see why is it that they picked that as their number 1. The second one is mental health. Anxiety, depression, suicide, PTSD, and others. Older adult health is number 3. Hearing, vision loss, arthritis. The 4th one is air quality. The 5th one is weight status. Overweight, obese, excuse me. And then the top 3 things that improve health in your community are access to affordable healthcare services. Number 1, again, houseless services or stable housing options is showing up as number 2. Fair and equitable access to jobs, health, and housing. Addressing poverty. services for families with children such as childcare, after-school options, parenting support, kindergarten readiness, and others. Crime and crime prevention such as robberies, shootings, and other violent crimes is currently 9th on our list at this point. Child access to healthcare, so that the thing that they were not able to get, so people with children, the number one thing that they were not able to access is mental or behavioral health services at this point. And for folks overall, when they don't access healthcare, we ask them why. And the answer are the wait is too long and the cost is too expensive or they cannot pay. So just sharing that brief, the first 800 folks, that's kind of what they're saying. So when, put my funny slide up at the end, and it's, we need your help. So we could use some help. So there are 3 people that are kind of working on the back end of this survey, but we need that partnership with you all to help us disseminate this. And so you all know the folks that you work with best. I'd be happy to meet with you one-on-one and see if there's a way that we can design information to get this out. So I'm just asking for your help and helping us hear from community members in our region. Any questions? Justin, of course, yes.
Like to talk to them, I'd be happy to let them connect you with those patients. It's a specific demographic. I'd be interested to see what their perception is.
I'd be happy.
And Teresa, you're saying the top issue is the total cost.
I kind of am. That's what, so far, that's what people are saying. Wait times. Yeah. So they don't access healthcare because of the wait. Any other questions?
I'm curious, like, just thinking how you the survey on. Yeah. It would be like tablets that would have a survey where people are waiting and like just do it like a library or a senior center or a clinic.
Yeah.
I love that. I don't know if you can do it, but
Yeah.
maybe another avenue to get more.
Yeah, so if your organizations would be open to doing that, we would love to partner with you to make that happen.
I've got ways to contact residents in each Rotary Club in the 3 county region, so that one click through our system. Communicate to everybody.
Great. Fantastic. Thank you, Linda.
Like, I'm sending them text to Judge Unincorporated,
Okay.
someone. So is there a link or something I can send?
I'll send it to you.
Yes.
Okay.
Rebecca, if you want to talk to me.
I'll reach out.
And waiting rooms of any medical, because you do have to wait for the doctor, especially by afternoon. So I'm just saying,
Yeah.
you're bored.
And I think that's kind of where I'm reaching out to you all to ask personally. You know, we would love your help in doing this. So if there's ways that you have ideas, we can't do it ourselves, so we need your help.
Rebecca, behavioral health came up, but it also isn't, or maybe it was a previous slide, survey topics. And my only surprise, despite having a really comprehensive list, is that behavioral health wasn't listed on there. So are you just waiting for that to come up, or was it just missing?
So on that, under the top household health concerns, there are about 20 choices that they can select from, and there's also an other option. Behavioral health is an option of those 20 choices. Same thing for that second thing, what would most improve community health? Behavioral health is an option for folks to select.
Do we couch it as behavioral health or do we couch it as mental health and other services? A way to break it down to where it might make sense. Some people figure out their behavioral health.
Yeah, so usually we have the topic and then in parentheses we give examples of what this could contain. So for example, the crime and crime prevention, it has in parentheses robberies, shootings, and other violent crimes as examples, so people could understand that that might be something we would select.
Thank you.
Yeah. Anything? Oh, go ahead. sorry, really quickly, I just was thinking, this is the first time that we as the region have also collected sexual orientation and gender identity data. It's something that's required by Oregon Health Authority, and we're really excited to kind of take a look at these results and see, you know, where some gaps might be highlighted in particular prioritized populations that we haven't been able to really get answers around. So kind of exciting to see that. Any other questions?
Is there anyone who is on the video that maybe has another idea or has a suggestion they want to offer? Brad, go ahead.
Yeah, if you want suggestions, for the communities such as our Spanish-speaking Latino community, other communities that are a little bit harder to reach, that maybe don't spend as much time on their computers, responding to things. It really takes an intentional, deliberate partnership. So I would raise up as an example, we just started partnering with the Latino Community Association. We just started partnering with Envision Bend. And well, we talked to them several months ago as they were planning, but just this month we implemented there, in fact, right where you're sitting. Milagros, our Bend client services manager, led an effort to get 100 survey responses to the Envision Bend survey. And that included $25 gift certificates or a card, you know, some type of a cash card. I forget exactly what we used, but I think a Fred Meyer card. And she got those in one weekend at two of our events, the Tianguis swap meet event and I forget the second event, but two different events that we had going on. And so that was 100 survey responses in a weekend that I guess it cost about $2,000 in gift cards. So it does cost. People who don't normally respond to surveys, if we want their data and input, it pays to pay. It pays to pay them for their time. So I just wanted to share that.
Brad, thank you. I'll be connecting with you about some ideas that maybe we can do. Gift cards are definitely on the table.
So we do have a budget for that? Do we have a budget for that?
We
Neil's the new ED. Right, exactly.
We do, we're good. We are actually building the budget for next year.
Okay.
And there will definitely be some resources for that. Seeking other grant funding to potentially support it. And we can't officially announce anything yet at this point, but we will eventually have a new hire that has expertise in that.
Wonderful. Good. Okay, excellent.
So thinking about strategies for Cook and Jefferson, and I know you know this better than I do, but public health has a lot of requirements. We have a public health expert sitting here in the room. And and then certainly community mental health has requirements that get covered by the Health Council. So I'm wondering whether we can leverage those resources. I'm sure Katie can advise you to that with her he or she's next.
I needed an excuse to take a trip to myself.
I've already sent Rebecca an email.
Very good.
And I've already heard from Commissioner Semmelak. He goes, let me ask Doc, and he goes, and it doesn't ring a bell for Dr. Baker, so let's get some feed directly to him.
Okay.
Is that amazing?
Perfect.
He said the Zoom volume is very poor, it needs to be turned up on an independent meeting.
It's as high as it can go, so it will be projection after this. We have it turned up here, we have microphones down, so we will need, I know.
Outside voices?
Yep,
Outside
projection
voices.
voices, yeah.
Thank you, Kelly.
Yes, Linda.
Two more thoughts.
Thank you.
They're doing an announcement at the city club meeting, they could send a link to their members. Chamber of Commerce would be another idea. And maybe having a visit with their bulletin editorial.
Fantastic.
To encourage them, to encourage those messages.
Great. Thank you. Those are great. I knew you were all great brainstormers. I remember that.
we gave a lot to you. Is there any of that that you need us to take on in order to be able to help shepherd, or do you have the capacity? Because I'm sensitive to saying, we just gave you 25 new ideas and good luck. Yes. Is there anything that maybe we could do, or if you want to, if there are things that you would like to ask us to assist on, please don't hesitate turning the conversation back to Tab.
Thank you. I will reach out directly and follow up with next steps with each of you. I appreciate that.
Great work, by the way.
Yeah, it's exciting, I think, for our region. This is something that the state is actually really excited to see as well. It hasn't been done anywhere else.
And it meets county requirements too, that needs to happen.
Yes, this meets public health accreditation requirements as a step towards that health assessment and health improvement plan.
Wonderful.
Thank you.
Okay, great job. Any other comments on that? Okay, next we will move forward. I'm going to turn it over to Brad. Funding update, CAP recruitment.
Thanks, Tammy. Yeah, just a couple of items to put before the board and open for discussion if there's desire. The CBI's community health projects funding update. So I'm not sure if the board members are aware that we started out with, I think, $340,000 for the community health projects to distribute out in grants, and then we got another $1.6 million that I'm going to ask somebody there, either Carmen or Michaela or somebody there, maybe even somebody in the industry to or maybe Pacific Source Tricia, to describe why we got this large sum of money kind of at the 80-yard line. So we're up to that was $1.6 million. So we're up to $1,941,000 to distribute out to community organizations. And I think, from one perspective, that's a great thing because there's a bunch of money available for community organizations to do their work. From another perspective, particularly of the Community Advisory Council, the CAC, it kind of turns us into a foundation. That's the way it feels to me. I don't want to speak for the entire CAC, but to me, it feels like all of it, we're now a foundation giving out grants, and we got 73 applications. So we need to review 73 grant applications, which is a lot of work. And, we could assign that to people who aren't CAC members, but then you lose, it could be the health council staff, it could be somebody who's contracted, whatever that looks like. It could be a foundation who actually does this for a living, or like community volunteers who maybe, for example, Oregon Community Foundation has community volunteers who review their applications in each region. So maybe we, hire those folks or don't have to pay them, they're volunteers, but get those folks to help review the applications, and then the CAC kind of oversees that. But then, as you do that, you lose something in terms of the perspectives of the CAC members. So anyways, I wanted to put that out there because it's a tension that I feel. Because again, it's a great thing on one side, and on another side, it's a ton of work for the CAC. And it also diverts our attention from what I think is more important, which is bringing consumer voice to the Health Council. So it's something that we're going to be discussing at the CAC, but I'd love to hear what the board thinks. We are advisory to the board. The board has made it very clear in our conversations, over the past year about the CAC and the board relationship, that you look to the CAC for consumer voice and guidance. So I think that's where we should have our focus. So I think if it's okay, I'll just open that up for any thoughts, questions, discussion. Tricia, I see you stepped up to the table. If you wanted to give that information on where the funding's coming from, and then we can open it up maybe.
Sure. Thank you for that, Brad. So the funds come from the quality pool payout. So based on 2021 performance, the Central Oregon CCO received just over $16 million in total payout. This comes out of the Central Oregon Health Council's portion of those dollars. So So we off the top split 50% goes to Pacific Source, the remaining 50% goes to Central Oregon Health Council. So out of that 50% at the Health Council, 35% of those dollars goes to provider partners, 10% of those dollars goes to SDOH, Social Determinants of Health spending, which is where those dollars funnel to the CAC grant. So easy math, 16 million means $1.6 million goes to the CAC for investment in social determinants of health and equity in our region, and the remaining 5% gets approved by the provider engagement panel. And that's 5%. So that's the overall picture of where those dollars get spent. And just a reminder, the right side of that, as I'm gesturing, is the Pacific Source side. And those don't get retained by Pacific Source; those are paid through contracts through our contracts on that side, through Pacific Source contracts. So all of those dollars funnel back into the community.
And so this year there was a particularly, what made this year different?
We rocked it. It didn't hurt that the metrics were rebased. So we got a bonus over a 2-year rebase program from the state that they said, okay, we're coming out of a pandemic. We're going to decrease the goals year 1, which is 2021, year 2, which is 2022, to help communities achieve those quality incentive measures. So that is some of it. The other part is not only did we meet our quality improvement metrics, we also met the challenge pool. So our community total payout was actually 108%, which is incredible. So we were on track in some places even before the metrics were rebased. Don't get me wrong, we'll take another year of rebasement if it's offered. But so it's that 108%. And I knew this question was coming, Brad. So I actually reached out to our quality improvement metrics manager, Andrea Kettlehut, who you all know so well. And she gave me some history that in 2018, we received a total payout of just under $9 million. And in 2019, the payout was again just over $14 million. So we are still, if you will, in that last payout ballpark, which again, as we circle back to the last board's discussion on cost of care and the importance of, doing the work in these spaces and supporting this work within your individual organizations and what it can mean for total payout in our community is significant.
We also changed the formula, right? Somebody would have to remind us of the year, but it used to be that the 50% that the Health Council retained was specifically designated for behavioral health funding, innovation.
That's not a shared savings.
That's not shared savings.
I know.
Okay.
But there was a time we did redo it though. I've heard we're at, years. The redo of the quality pool was for 2.0.
Okay.
So for 2020, it measured there. And that it was just, it used to be 60-40. We changed it to 50.
So I think it's important though that we don't lose focus on the metrics or I'm not saying that we've done, I'm saying that because the point was that 70% kids in, so they moved down to 50%. But we made a metric that we still have a lot of kids who didn't get in. And I think like if the goal is to do really good healthcare and total cost of the event curve, it's great that they rebase and it's great that there's this funding available, but it means when they decide that the rebasement period is over with, it's going to be that much harder to get there. So we should really try to take this time period and think of how we're going to meet those metrics, deliver that care to the kids who need it, deliver that care to the adults who need it, and not try to work funding from that to pay for what's already a very expensive system. Like how do we use that money to get everybody ready for when the rebasement is over?
And sitting in on the quality improvement metrics meetings, which I did with Tricia there, everyone is painfully aware of that.
That it's coming or they're prepared for when it does rebase?
No one's assuming it's getting.
Well, my group is 100% we're preparing. Assuming because
we're assuming that we're back to
the targets will come.
high metrics. We're not assuming that
It's going to stay low.
Christmas will happen.
Linda and then Dan,
Yeah.
yes.
I sit on the CAC with Brad, and
know the staff has been doing a great job trying to help step up to the task. It reminds me of years ago, 4 or 5 years ago, when this council was reviewing grants. And at some point asked ourselves, well, why are we doing this? It makes total sense to me that we would be asking CAC to review these. And yet, we want to hear from CAC about their experience, and we're doing some developmental work in that regards. And you have 73 applications, and you're not retired or have people who could do that for you. It's a big ask. Yeah. For people who aren't, and I'm retired, and it's still a big ask.
And one idea off of what Linda said though, Brad, might be, does the CAC have a universal opinion of the #1 problem it wants to tackle? Because if you do, you can send out grant requests real quickly if 90% of them have nothing to do with the topic you want to focus on.
Yeah.
Oh, go ahead, Brad.
Way to send it out.
I was just gonna say, I don't think that's the case exactly. I mean, we have emerging issues that we're looking at, like dental, periodontal. We see a huge gap there. And a need for some advocacy work to be done to change kind of the system. But as far as work on the ground, I mean, we're looking at, you know, does it address the social terms of health? You know, equity is a big piece. And rural is a big piece, so that not all the funding's going to only to Bend. So those are kind of our directional focal points. But as far as like a single issue, no, there's not a single issue.
I mean, in developing the structure though, because it sounds like this is going to be the first flight that you have to make, and you need a structure for making that first flight. It might just be smart for everybody to say, hey, the #1 thing we want to tackle, let's say it's dental or anything, whatever fits with the social determinants of health that you guys are really focused on. Put all your effort and money into that for 1 year if it has really well-defined metrics for outcomes. And then if that works, then have a structure for every year after that, rather than trying to figure out how to sort through 73 grant proposals that may or may not fit with what you want to do in the first place.
So we might also want to make sure that we're being clear on what it is that we are asking people to apply for, if we're going to set criteria after the fact. Well, yeah, so clarity of what it is that the funding is available for might be. Yeah. So, Kate, go right ahead.
No, I would like really have some people lose their brains.
Oh,
They wrote
okay.
applications not knowing how they were gonna be at this point, because they invested a lot of time to write.
No, it's a great point. I mean, but it's almost, you know, we asked everyone, they brought us shiny rocks, but we wanted sticks. So, I'm like, no. Dan, please.
I was gonna go where Linda was, and if there's, you know, if you spend 5% of the money, just as an example, to really help go through the grants and allocate the dollars to the best, you know, either sustainable or the ones that have the tight metrics or what have you. That feel, and I'm making up the number 5%, but that feels like that might be a money well spent if that honors the CAC's time and makes the process work. So just as a
Carmen.
I mean, I think that this alignment and criteria is important to have, you know, moving forward. But I do want to recognize that this, the application's more than this year. So what that actually says is that more people are accessing this information, is what we want. So, and Michaela and Glenn and the rest of the team have done an incredible amount of work to structure it in a way that is equitable for lots of folks. Recently, you mentioned that.
And I think this is in the same line, I tell people or not, in the last legislative session, at the last minute, the Oregon Association of ESDs was given $50 million to hand out to all community-based organizations for educational covering unrelated to school, so for CBOs to do that. And it was originally the Oregon Community Foundation did it the year before, and they said that we don't touch it this year, so we won. And so Central or High Desert BSD had $6 million to give out. We found out in May, had to give it out by June we spent a chunk of our money hiring people to say, what are we looking for? What did we put out there as what we would say? And we had 50 something applicants in Central Oregon and got it out the door. But we had essentially almost a full-time contractor working behind the scenes. And then we had a group of 6 people who went through every one of them, gave them a ranking based on that, and then pulled in our equivalent to the CAC and said, here's what we think. Do you agree? Do you want to make a case for anyone who didn't make it to the top? I think that's what I hear you saying, Brad, is can I get some help here? And I think 5%, whatever that amount is, can we get some folks to help out with this?
It helps remove the emotion out of it too, which is when we're, individuals, volunteers or those that are, it's a great opportunity to be able to support your community, but it's difficult to not have it just be subjective to what you personally feel like you might want to invest in. And so it makes me think of the CARES funding and the support through the counties, with our organization being able to develop a scoring criteria that took a bit of that out of it, and then allowed the committees to then determine the best path forward. So yes, Rick.
Where I'm going, sort of point about how not to do it compared to what how they did it is Measure 110's oversight and accountability committee. They get a group of people with no grant experience. They hadn't even written a grant.
Sure.
And some of them are still using drugs, literally. And they got to invest $270 million with minimal staff support. So it was a stunning process, not very legal. And so the takeaway is citizen input is huge, but to do that without staff support, helping them understand how to do this in the process is really disservice.
So with all of that said, Brad, is there a specific ask to support the team? I mean, I know you have staff support. Is there something that subgroup, or is there anything that specific that you can identify that we can assist on?
I don't think for this year we're already in motion and we're going to do it, and so not this year, but moving forward. I mean, the other thing when I first found out that all of a sudden we went from $340,000 to give out in grants to $1.9 million, almost $2 million. The other thought that crossed my mind is, well, is there kind of like on Justin's point, but is there like one need in the community where this could actually really move the needle, like where we just put all or most of that money toward something that really needs funding to make a difference? But we don't have the time to have that conversation. It's kind of like it's a process question also. If we're going to continue to have that kind of money available, is it smarter, wiser to give out small grants, $80,000 or less to each organization, or is it smarter to spend all or some large portion of that to address an issue where we could really make a difference?
Or maybe you split the funds and a portion of it is spent one way and the other portion, a larger share, is spent in another. So it sounds like maybe a debrief after this process is complete and take some of these suggestions and ideas into account. And if there's a structure that any of us that have done some of that grant wrangling, if you will, can offer, or anything that we can help in terms of structure for this next go round, I think our hope is that we generate more money to be able to give out and reinvest than less. So, let's use these as opportunities to learn, and we'll just refine the process as we go forward. Does it sound good? Is there more there that you need, Brad?
I don't think so. Just, after this, if people have other thoughts, please share them. If you have further thoughts about, what this could look like moving forward. The only other thing for my portion of the agenda is CAC recruitment. We haven't really been putting a lot of energy into that, and we need to. So that, again, it's kind of that having the time and energy for a volunteer board to achieve and be successful at having a council that actually represents the community we serve and the consumers is really should be our highest priority. And we've heard that from the board as well. So that's just another kind of CAC purpose and priorities question. If the board has any feedback on that, we'll be taking this back to the CAC too, but we're working with you. We're working with the board. So with the council.
Great. Any comments on CAC member recruitment?
Do CAC members receive a stipend? What's the compensation for participation?
I'm not entirely sure. Brad or Linda, would you mind, or Michaela, the stipend or any sort of support for CAC member participation?
Yeah, so consumer representatives get $45 stipend per meeting and a $10 internet connectivity reimbursement. If they have to travel for a meeting, then we reimburse for mileage. If they have to do work outside the meetings, like review these pre-applications, then they'll get a stipend as well for that work as well.
Wonderful. Okay.
And then I think we're also be reevaluated as well, as far as the amount. Just inflation is a real thing.
You bet. So Iman is suggesting, Brad, that I'm not sure if everyone can hear, but that we revisit. Okay, very good. I think it's an excellent.
With virtual options, how we consider membership for elderly folks who maybe don't want to attend meetings.
Sure. So the question that Brad is around whether or not virtual participation for anyone who's maybe doesn't want to travel or
Love to participate in
yeah.
time, they want to do it virtually, but they really, they're maybe not, transportation isn't such an easy gig for them, and they're,
Yeah.
not an option.
Is that an option?
I couldn't hear Justin very clearly that last part.
So is it an option for CAC members to participate remotely as the way that they primarily participate due to maybe not wanting to travel or other
Yeah.
limitations? Okay.
Yeah, in fact, right now we're still 100% virtual. What was that?
Okay, great.
And dual eligibility. People who are Medicare and Medicaid eligible, and they move between the two.
People that are Medicaid and Medicare eligible, are they able to participate?
Michaela, I'm only aware of Medicaid, but Michaela can answer that better than me.
Great question. I didn't know.
Yes, to roll in
The
CCO.
answer is yes. Okay. Oh, good. And Justin said he can get you some people.
So this is Justin's action item.
Right. We'll get him a bigger piece of paper.
Hey,
Yeah, he gets 2 cupcakes. Oh.
That'll be the last ask is, yeah, if you could use, oh, sorry, Dan, go ahead.
No, you're good. You go, and then I'm gonna go back to the first topic if the chair allows.
Okay, I was just gonna say the last ask is if there's anything you can do to, help us recruit. And we can, you can ask Michaela and Gwen about the gaps that we have, the actual people that we're looking for to help us better represent the community we serve. That'd be great.
Excellent. Dan?
Is that okay?
Yeah.
So Brad, you asked kind of on just feedback on that first topic, the grants and the allocation. I just want to go back to Justin's thought, because even though we wouldn't want to change the rules now at this point, but it would be really fun to hear from the CAC if we anticipate more dollars coming in through this channel. Would they rather, for a next time around, solve a couple problems as opposed to throw 20 pebbles in the pond? So just, Brad, that would be really fun to hear from them maybe after this cycle as to what they think about that for future cycles.
Also,
Yeah.
Brad, the idea, how you structure those, you could put out 1 or 2 big grants, but pay out over 5 years. So there's better sustainability than just a big splash 1 year. I think that's a big critique of any of these programs is, do they first they ever have enough money that they can actually make it? Second, if it really works well, how do you fund it?
Right.
Right,
Or-
and really 5 years, because you're gonna spend the first year getting it stood up and figuring out how to do it right.
Trisha, dive in.
Yeah, I just want to caution that these dollars come with some guidelines from the state. I want to lean towards some stringent guidelines, including spending them out in the year. So we are sometimes coming down into December and cutting those checks. So we will need to vet whether or not once we cut those checks, at what point that organization can spend. And then also just the idea around administrative support. Also, we just need to vet, these are great ideas, but we need to vet that these specific dollars that come down for health-related services from OHA qualify for these kinds of things. If you have Kristen Tobias at the CAC and your CAC leaders, program and project managers, who can help along those guidelines. But I just wanted to add those two cautions.
Yeah, in years past, who knows what happens now, but so long as the CCO spent it, that's what counted for getting it out. But
I mean, if you're an audit someday. And also they have, I mean, historically, OHA has not done that in other CCOs, that they have not honored that in Levy Lunch, for example, we did previous years. So there is a stipulation in the JMA that says that you need to spend money for trainings and receiving. But I hear a baby.
I'm kind of intrigued by the idea of doing some training, a broader pool of grant reviewers that could then cycle that up through, and we could use the funds for that.
I also would very much like our CCO to press the envelope to hold OHA to their desire to promote equity. Like the usual rules do not apply if we really want to honor the CAC and their initiatives and even the process around them. You can't like not compensate people for doing meaningful work. It's disrespectful and I would say anti-equity to just assume that community members are going to volunteer to do it or do it for $45. Like I honestly think OHA needs to be courageous with that, and that our CCO should advocate for that type of policy that truly represents the issue of equity. That I see a lot of PowerPoints around, but I don't necessarily see policies like that reflect it on the ground.
Excellent point. Let's underscore that. And
and we should develop those and formally hand them off to OHA as our request.
And so is that so we can augment, could we not augment what we're currently doing? There'd be no reason, or is it possibly that might not be an allowable spend?
I would look to
Please don't
my-
do that.
You're getting a little over my years worth of experience.
I think that the OHA is fine to reimburse CAC members for their time, and however it's spent. Okay. We've received some guidance.
Well, that and also how the money is used to do year over year social justice equity work is not in an annual cycle. Sorry. So I think it's just an overall policy pivot that I think reflects and authentically embraces what OHA is putting out in writing.
So maybe what might be beneficial is when we do the debrief, what barriers or restrictions did the committee feel were keeping them from doing the things that they felt were best in the best interest of the community, meeting the needs that we have within our own unique geographic area. And if we can identify some of that, maybe then we can capture that as our statements and our feedback to the state. We could have made a more meaningful impact in the following if we had not had the restriction of XYZ. Is that maybe where we could develop some feedback that we could give back to the state?
And I don't want to get too much into the weeds, Tammy, but I feel like part of the barrier to doing innovative work that is meaningful to the community is this short life cycle of known funding. Sure. So so that rewards more established organizations, right? So it reinforces the current structure, who's gonna be courageous and brave and start their own, you know, dental clinic?
It's also
In
difficult.
an innovative way, if you only know that you're gonna get 12 months of funding. So again, it's a bigger policy issue, and perhaps our small group of people will not, overtake OHA's funding cycles, but I just think that it's a philosophical barrier to doing meaningful change that, again, OHA has backed themselves into a corner if they truly want to fulfill their goals around equity. I think that they have to approach the work differently.
So there's another strategy to get to your goal. As a nonprofit director, I'm scheming always. So what the CAC can do is set, hey, we have these 4 or 5 priorities. And we will, and these are the people who win the grants. You have to spend your money every year, but you're going to be first in line for next year's review. That's an internal policy. So you're making decisions within the CAC tentatively, if everything's working well, to each year renew that grant for up to 5 years. And that way you meet your need to spend the money, put it out each year. You split it up into some priorities. You have some sustainability. And then if the small nonprofit that you funded goes kaput, you can repivot that over the year. So that would be one way of structuring to have your cake and eat it too.
Well, and I think that's where we want to be. So let's capture these suggestions. Brad, it sounds like we'd really like a debrief after we get through this process. Be able to refine how we might be able to first provide some feedback to the state, but then also see if there's a way that we can support the efforts that the committee wants to achieve in a maybe creative way. And so does that help with today's conversation and get you what you need, Brad?
Yeah, no, I appreciate all the thinking and ideas around it, and look forward to continuing the conversation. Thanks, everybody. Yeah.
Thank you for your leadership. I know you have a few other things going on, and it's not a small lift to guide this group, and it's really wonderful to have you and Linda helping. So thank you for doing that.
Oh, yes, I just say thank you for the $250,000 for the stabilization center grant that we just announced yesterday at our meeting. So thank you very much. It's incredibly appreciated. And, with the CJC funding of $2.3 billion, have the facility open 24/7.
Yay.
So it just helps.
That's a big win.
Yeah.
That is a really big win.
Thank you,
Yes. Okay, cost of care follow-up.
Okay, so last board meeting, we had an exciting cost of care discussion. Thank you, Pacific Source, for all the amazing information you provided. I think it really created some energy in terms of how we move the dial. And I didn't want to lose these recommendations. And so we are going to strategy summary. We're to 3 recommendations. And I just wanted mostly to update that the low value care piece has gone to PEP, Provider Engagement Panel, as recommended by the board. And the other 2 pieces, and this is something as we're starting to, and we'll talk about this during our strategic planning update. Our board is going for a retreat in October. And we're taking a look at how Ops Council, so for example, this very topic that Brad just discussed, we're talking about it here on the board level, but bringing this information into the Operations Council and having folks, work on these topics. And so that it can be directed into the right spaces. There's also another committee that we have, which is CODI, which is our Diversity, Equity, Inclusion group. And I think that piece, as it continues to grow, will feed into these pieces. Iman, as you mentioned, this piece really needs to be infused into everything that we do. And I believe that our team and this board believes that as well. So that's just an update to just let you know that these items, because I find a lot of times that we talk about it and it's really great, and then what happened to it? Where did did it go? We were talking about this. So anyway, I just wanted to give a brief update, and I've been working closely with Tricia and, you know, the data analytics team and the support that we're getting from Pacific Source. So,
Yeah, I just wanted to add on, I'm excited, actually, mainly. Way that she did it. I mean, I group in particular, 3 years, really 4 years, we've significantly our total cost of care, our medical loss ratio, I think Pacific Source knows that. And we've sat back each time wondering how is it that, you know, we're saying healthcare is so much more expensive and so much more is utilized in those really high cost settings. And to see a 3-year data trend where that's absolutely not the truth, that isn't what happened. I mean, what I thought was great was watching kind of confirmation bias with data sets. Because if healthcare is more expensive, or it's overutilized in a specific place, well, that's obviously it has to be true. But if the data set says something completely different, well, it's just a pandemic and it's noise in the data. You pay me to mow your lawn once a week, and I mow it every 3 weeks, you're still paying me to mow it a lot more than you should be paying for. That data set, I took a few screenshots and did my own little p-value on it. It's a very strong correlation between the trend lines as they follow month over month. And there's a 31% reduction in patient spend and ER utilization.
Can you say that again?
There's a roughly 31% reduction over the 3-year period in the total spend on inpatient and ER utilization collectively. And then there's a significant spend increase on behavioral health. The point of the health council, my group always sits back and goes, well, geez, if we're doing that good, how bad is everyone else doing? Well, they're not. Data set clearly shows the concept of health council is working. The concept of investing in behavioral health is working. Now we need to make sure the contract aligns to where the money is spent. Because it's absolute, the data set's irrefutable. 2019 to now, the utilization of high cost resources is not what it was. It's just not. So hopefully we don't use our own confirmation bias and just discount the data. So I really appreciate that you're taking into the absence of confidence, and I hope it informs the contract negotiations because it absolutely definitively proves that the work we're doing is working. So I hope everybody, especially the work with behavioral health, I think there's the strongest correlation between the 3 charts. The increased spend in behavioral health, increased spend, total cost, and high cost cases. So pair up each one of those charts against each other and run your own p-values on it if you like.
Oh,
Very,
no, I
very
mean,
impressive.
I'm really, because I know the data of our folks that are using the and we can engage them in services. We can hook them. Their utilization drops 90%. It's dramatic.
You can see it in the data set.
The stabilization center kept 660 people from going to the ED. So that was my number for 2 days ago.
So the spend for these, hopefully as we continue to evolve this in the Ops Council, the idea should be how do you support more of that, and you're paying for something that isn't being utilized the way it used to. And that's how you pay for it. So thank you, Pacific Source, the data set is amazing. My favorite meeting in the health council.
Nice job, bro.
How about this one now?
That one was better. It was just amazing to finally see, you debate, but eventually there's got to be one source of truth. And if it had said something else, then that would have been the source of truth. But it said one thing, and I hope we don't spend a lot of time trying to argue out that it said something different.
It's less subjective. I mean, we all put our own opinions into why we see whatever trend is happening. But it's also a time which I don't know if this is my own experience, but where people stop doing what they were doing because it's working and it's starting to show some sort of a change, but then we just for some reason let go of it. And I just would encourage us to lean in further versus sort of feeling like this is the time to coast a tad. We have a lot of need in front of us, and I think we're hearing it in Rebecca's report in terms of the community still identifying access mental health services. I mean, we still have significant need. Well, I don't wanna rain on your parade of excitement, but we still,
No,
we have.
it should guide a lot of the actions forward, like you're saying, that,
Absolutely.
they are, the general population is saying, I need better access and it's not cost effective. And we have a pool of resources we can utilize. Does it make sense to pay for the most expensive level of care when it's what's not being utilized? It probably makes more sense to figure out ways to carve some of these things out and push that towards the things people are asking for, more access, more options. It was just good to see something to find.
So, Chair Beatty, an interesting dynamic, I don't know where I'm going with this, but in my world, we're seeing an absolute explosion in mental health problems. The level of severity that people are coming in with is requiring our providers to change their prescribing practices, just to how to detox people. They're coming in at levels 6 times what they were a year ago. The standing joke, and just they say this, is heroin is harm reduction. What's going on? And interestingly, when we check with our staff and the EDs, they're saying they're not showing up at the EDs. They're not showing up in the healthcare system, but they're overdosing in camps. So there's, and what's driving the ED is alcoholics. And then meth is all mixed with fentanyl too. So we're seeing this just explosion. And this is not related to Measure 110. This is related to drug cartels finally moving to a small market of Oregon, but other states. So it's crazy out there. It's not uncommon to take 6 doses and back into your body. So that's just like this big change that's happening in the last 6 months. Just interested to see if this plays out in the reality that we see.
What was the average of the death data? 19, when in 19 to when?
It's in the 18 up until current.
You guys, the paper the other day had said the overdoses had doubled from in Oregon from 2019 to 2021, but it was on the 7th page down in the far left-hand corner. And how many people read? And it was from OHA. So I'm so worried about it. And the other thing yesterday we learned was that there's a suicide every week in Deschutes County on average. And I'm trying. We've got these signs down at the bridge, the Crooked River Bridge, but it's a Jefferson County issue, I guess. But there's these signs and they kind of just blend into the environment. People worked on them. But I said, can't we like put hearts on them or something? Because I have been called every time somebody jumps from there, people know to call me. And I just said, can't we do something so people actually see those signs? I went down there and I took pictures and I asked people that were there at the park. And I said, did you guys see the sign in case you're here and you've got a health issue? And nobody seemed to notice them. But this group worked on them, but they made them blend so into the bark and the cup. They're all really soft.
Yeah, I was actually on
Were you
a small
part of?
committee to put that in there. There's amazing amounts of rules around that.
I know that people are still jumping and they want to actually change the phone number on the sign, so I'm trying to get that
It should be 988.
Yeah, I know, well, that's what they're trying to do, so I'm
But we
trying to.
didn't have 988 when we designed those signs.
But that's one of
And you can't do
issues.
fencing.
I mean, suicide, not just jumping, but you have people who jump.
So in the past, when we've had community crisis such as this, we've wrangled it a bit differently than waiting for a response from either the state or other communities. Thinking back to the Meth Action Coalition in terms of awareness and knowing what it is to be looking for, the prescribing practices and initiatives that have been born out of this body to be able to address. And a lot of it was around the education and awareness around the dental community too. Why on a Friday evening am I getting calls from my clients who are in need of XYZ when it's to get, to the weekend? And I just wonder if maybe there isn't a space for us to work with Ops Council to step into this a little bit differently. The difference with fentanyl is that the ability for someone to survive is, it's, the numbers are not gonna, the recovery numbers are not gonna look the same because recovery, I don't wanna be morbid, but it's chances of an overdose and the use is high. So getting ahead of that, isn't quite the same as methadone or something and trying to get someone off something. But to those of you that are doing this work every day, is there a space here where we convene a small task force to look into it? And it kind of goes into this next subject where there is a lot happening in the community around community violence and around gun violence. But on this specific topic, what are your thoughts?
Well, and my esteemed public health director chairs the regional task force.
Okay, so go ahead, Katie.
We are just evolving from a task force to a coalition as of today.
Oh.
Because our work is not ending. So we inherited the overdose crisis response plan that Pain Standards Task Force drafted.
Okay.
We were tasked, this task force was charged with operationalizing that plan 2-ish years ago, pre-pandemic. We'll go with that.
Okay.
And so since then, we've been convening to stand up surveillance, communications, and response pathways for responding and doing work to prevent overdose in the region. There's about 50 people engaged in that body of work throughout Central Oregon from a variety of stakeholders, as was outlined so well in that original plan. And at any given time, we meet every other month. We welcome additional engagement. Carmen said in this week, we met right before this meeting. We have not had one of the struggles we've had is we haven't had consistent funding. I think this has come up pretty regularly. We rely on about $100,000 budget for the Central Oregon region a year that we receive from Oregon Health Authority, and that funding is always up in the air. It gets funneled through from federal sources. And we pull together grant funding, and a lot of times our partners and stakeholders just show up because we know things done. And public health has chipped in epidemiology support, our hospital systems chip in, we all chip in, but for the past couple of years, we have been wrestling this issue. We do I speak to the media on a very regular basis to raise awareness. We bounce ideas off of, we have a core group that I'll say, hey, I've got another call from the source or Bolton or someone, and I'll gather the information from our region, and typically the one on the Zoom screen or something to share out. But we would absolutely love additional stakeholders and voice and input. It's a heavy lift, and it's our harm reduction services folks are on the ground, and they're supporting the work that we're doing and speaking into it, and are a great resource for us. Jeff Coe we now have harm reduction and syringe service programs and connections to treatment in each county, which is incredibly exciting, and that has been born out of some extra support from this group that's been meeting. So there's a whole lot to it, whole lot to it, but we would love the additional support and engagement. Yeah.
Just it's a recurring theme though, is like how do we find the funding to stand up things that really matter? Years ago when we had the conversation about the budget, we said, boy, it is $300 million, all adds up. If you can save 1% a year, that's $300 million. I wonder if the idea should be, because what gets looked at is what makes the most noise, but usually it's not what drives the most noise. Kidney disease, absolutely chronic, congestive heart failure. I mean, congestive heart failure patient will probably make 15 trips to the ED before the end of their course of treatment. We don't do very good in mental life coaching, management, sand forever, obesity, chronic conditions. I mean, how do we tackle some of those things that are what really drive costs to shift the money to be able to do some of these really important things that aren't funded? And I go back to 3 years ago, we were talking about this when we first came to Health Council. We were looking just at the line items on what's in the cap and how that whole conversation. Either healthcare leaders believe it's a zero-sum game, or they believe that you can find the efficiencies because there's an system. It's got to be one or the other. But if it's always zero-sum and it's just always put more in, then there's never going to be these other items. But I think if you've been in the business long enough, you've seen what waste looks like, you know there's an awful lot of the system. So I think we should find a lot of it. If you would maybe prioritize some of the things that aren't as loud right now, but are very like. So maybe that should be one of the things we talk about. Chronic kidney disease, congestive heart failure, obesity, some of the things that are really dragging the pieces of spend. Get people out of beds on time. On down the line, there's a whole bunch of different things that create a lot of spend that doesn't add a lot of value. And is that an opportunity to do something with the Health Council as a group that's unified, and then can we talk about how those funds can be used to do something?
I think you raised an excellent point. So let's hold on to that. Divya, go right ahead. Nope, you're good.
Yeah, I think when I think about this issue, one of the things it's really actually great to hear about this coalition. And I just wonder, because it is so multifactorial, as you stated, and there's such an intersectionality from public health side and obviously just healthcare in general, but the criminal justice side, community-based, from our it eludes me, the councils, each of the, what am I looking for? The city councils and all of those, in terms of resources and funding, but also just a comprehensive plan. Because one of the other really concerning issues right now, which is what's creating this, is going further upstream, is a lot of the medications that are getting laced with fentanyl that are out in the community. So exposure to those and just they're so ubiquitous within the community. And so kind of closing that upstream, which is what's creating in our kids, not just this risk for overdoses, of course, that's huge, but also just these kind of addictions and things like that they're getting addicted to, because let's face it, we know they're actively having parties and in school system where they're having exposure and access to these medications. So I guess what I'm trying to say is, to me, supporting this coalition's work is important. And the Health Council side is just the one arm of this, from even structural change and funding. So I would love to see other stakeholders at the table coming together with, again, when I think about this from the Bend City Council, from other areas and avenues, and where you look at all the funding sources and go, okay, comprehensively from every sector, the funding, and then what is the plan? So it's getting tackled at all different ways. I don't think, to your point, I don't think $100,000 relying on that from OHA is really going to make a big change when there's so much adversarial force in our community, and it is a huge issue that is worsening. So I don't want this. I guess what I'm saying is I would love to see some kind of a thought that is with all those other stakeholders coming together, and then Health Council is from a funding source, a piece of it, because there are so many different arms. And if you tackle this comprehensively, maybe there's extra funding in areas where we're spending dollars that don't make sense for those dollars to be there, but they need to be diverted into this other work that, so again, we think about in healthcare, the waste, it's about putting dollars where there's impact, but that means taking dollars away from where there is no impact in those things. And it's kind of the same model, kind of what Justin was alluding to, is it's a finite pot, but there's so many inefficiencies. So how do we come together as a community at large, not just from the Health Council? But that also, I want to make it very clear that I fully support this work, and I think it's a really important work. And if Health Council can facilitate that work at a larger community level with really having those critical pieces and entities at the table to figure this out, it's not going to just come from just some funding that say we support.
Thank you for that, Divya. Do the members of the council feel like your organizations, or you in particular, have a good understanding of what it is that the coalition is doing? Or is there maybe an opportunity for us to get a little bit more informed about what the coalition is doing? Not to put you on the spot, not for right this second, but then also be able to walk this back of, okay, if we see this as an emerging or urgent need today, what role is proper or fits nicely with the council? What gaps are present? Whether that's funding, whether that's knowledge, whether that's programmatic, I don't know what it might be. And then we sort of wrangle this a little bit in terms of how do we then figure out what the proper role is for us, what we can impact and affect, but maybe even as individual organizations, what can we do to also maybe influence or impact as well? Can we tee you up for something like that? Okay, I'm seeing, does that work? I don't want to speak on behalf of the council. And some of us are more informed than
Related
others.
to this
Yeah.
is the implementation of the Measure 1 and behavioral health resource networks, which is we're hoping for openings early November in all communities. So that would be basically gives us funding to create an army of outreach workers.
Okay.
To this population.
Okay, so Rick, for those that may not have heard, but Rick is talking about the Measure 110 funding and how that's coming into the region as well.
And so it's tightly related to the goals of the opioid coalition.
I think we landed on coalition today.
Okay. I know like feels stuff issues, so
So if I needed to detox today, how long would I need to wait?
we can get you today.
Well, seriously, if someone, yeah.
No,
But
how
are
we
we,
have it set up, really, we prioritize the emergency department.
okay,
And so if you're in the emergency department, we can pull you in right now.
which is incredible because it hasn't always been that way. It's one of the struggles has been if we have individuals that are, yeah.
And so our priority for the detox is current patients in the ED or people who used to be there, because we want them to come to us as they cycle through. Instead of the ED, we're nicer. We have more comfortable beds. Sorry.
I think that's the big.
I agree with the bed part.
And we have much nicer, and we have an opportunity every time to engage them in treatment.
Okay, wonderful. And I think that's an important statement for us to make because I think some in the community feel that we maybe don't have access. And so, that piece is critical. So,
And are the schools across the region going to be working with the coalition? I was just sharing with Rick at the end of the 21-22 school year, we were seeing fentanyl usage in the larger urban areas affect teens and adolescents. As a smaller markets. So we're just not seeing yet, I'm not seeing yet, influx into the emergency department, but I think now that school started, we will start seeing it. So if we do something, and I would love maybe in October or November, report out to health council by the coalition, but just want to make sure that the right folks are there, so.
So short answer is yes. Very short answer, yes.
And is it at the superintendent of the regional schools, middle and high school level, or?
So that's coming, so that's me.
Yeah.
Yes, we're not beyond the grounds folks knowing what's going on all the time. We're making sure that those who know what they're talking about are at those meetings, and yes, it is showing up, even though they're not showing up here. And it's happening. Ontario just had last week a story about it that they had to do one of the high school students. So it's here.
So then it's not just with the schools, then it's like connecting the dots back to the families, which I know is the eternal struggle of schools. So anyway, I would love to hear the status of that work and then how I mean, this is like such to Divya's point, it's just like CAC dollars should have been allocated to help support this emerging challenge, and how do we get ahead of things rather than chasing things a year behind the funding cycle. So,
but I think one thing that has been a beauty of this organization is that we can find funding and respond if it needs to happen. And so I would encourage us to, if it makes good sense, we will find a way to make it happen. So yes, Linda.
I would challenge us to think about what we mean when we say health system. Traditionally, we say health system, we think about that part of the continuum, the people in this room for the most part, not health people. That's where the money comes in, that's where the money gets spent, it's where we look for savings and things like that. It's where the train wrecks are. And we sort of have this fledgling public health underfunding initiative, which is the goal of what we want to be. And I think of them both as a part of the system. It feels like a large part of this discussion today has been historically funding the care or disease part of the system. We'll never solve the problem until we can create some balance. And how do we shift our funding and not saying, oh, we're taking it out of the system and putting it into public health. But just start thinking about public health as colleagues and equals at the table. How do we shift those dollars and what we provide so that we have a better chance to get ahead of it, which theoretically in time will reduce the train wreck side of it.
Which is exactly when we first started this initiative 10 years ago. It was, how do we talk about actual health of a community versus medical payment reform, medical care. And that is a big divide between the two, and it's not easy. I mean,
should there be a divide?
Oh boy. Well, but yet, if we traditionally fund the things that we've been funding, we will never get the outcomes that we're hoping to achieve. Because if it were to happen, we're spending more on the same things, and we're still not getting an outcome that we're hoping to have. So I think this is a really rich, important conversation for us to continue to grapple with. And
negative reinforcement is always reinforced unless you introduce some type of unique action that changes the reinforcement.
Yes.
So, the idea that it's zero sum forever, keep you in zero sum.
You bet. Yep.
Right. So you have to introduce, and they may not be the things that everybody sees as the most visible. Like gun violence is probably much more visible now, but there's an awful lot of cost written off about it.
Right. And tragedy. Yep. Thank you. Yes. Yeah, that was great. Okay, good. And Katie, if we could talk offline, we'll tee something up and make sure that, yep, absolutely. Really good discussion. I think it's a great segue into when you're talking about the health of a community. There were some that were asking, well, why would we have education at the table when we're talking about, the coordinating care organization. And so our next topic is around community violence, and in particular for us, we've taken on looking at what's happening in the community around gun violence. And at the forefront of convening a lot of that work and participating is our schools. And so not unlike what you just mentioned in terms of some of these other pieces, it's really great to have you and to have our school systems a part of the conversation as we're talking about how we change the trajectory of our communities. I don't have a lot to update from the committee, but we have committee members here. We are continuing to sort of uncover the great work that's happening in the community. I will just share that, obviously the, wind out of my heart with the tragedy that we just experienced. But in that, I also will just say how proud I am to live in a community that responded in such a meaningful and timely and comprehensive way. And I know that many in this room were part of those conversations of what can I do and how can we help and what is needed, both for the individual who took their own life and the lives that were lost in that moment as well. To the schools of opening the doors to be able to have Deschutes County and a number of partners there to respond to those that were witnesses and respond. In your packet, you will see a note from Janice Garceau, who also congratulations to Janice, who is now the new Health Services Director for Deschutes County. But I think there is an action for us today in this space, but I think it gives you an idea of should we have a tragedy of which we did, what is the response that would happen? To this point for the committee, we haven't necessarily identified an actionable something, but what we have identified is that there is a lot of action that is currently happening in the community. And there's also clearly a nexus into our suicide rates and gun violence and community violence. So we are continuing to just do what we can to uncover that information, and then we will bring back if we see, things where we see a role that would be clearly identified for the Health Council, or a gap maybe that the Health Council could step in and possibly either help fill or discuss, or anything else that would be sort of a gap for the community. So anything else in that space that committee members would maybe want to add? Katie, you look like you had something to say. Go right ahead.
Just that we are making progress and that we're in that data collection phase of really wanting to understand what the issue is in Central Oregon. Without making any assumptions, I appreciate Justin talking about that. We can assume, but until we see the data and really get out there and dig at the issue, we don't want to necessarily take any action that may be in the wrong direction or be duplicative and not effective. So we're doing our due diligence as the hope in truly understanding as much as we can what the root cause or causes are and what the situation is.
Well said. Anything else? Any questions or any, we were bringing this forward as a subgroup of this body, and that's the work that we're doing. So if we're in the wrong direction or we're missing something, please let us know.
I think you said it, but just in line with that, in terms of the not being duplicated, it's also we're doing a great deal of research saying what is going on, what is happening, what we make sure so both are happening at the same time.
Okay, that's the update. So governance.
Yes. Seems like a year since we last met. I think it was last April. And so we've got two members on the committee since we last met. Yvonne is now on the committee, as is Katniss Angelo. And
Toronto was wild for a minute. Sorry, I was.
So we expanded committee membership to allow for us to get some more expert voices. We've gone through the last 2 years, governance committees that I think the painstaking painstaking work of working with the council through the mission, vision, values, bylaws, policy books. And we've got a list of to-do things that we have a work plan that we can talk about later. I wanted today just to get some feedback from the council, looking forward to the next year. We've got some to-do lists, but I think our role is to really be responsive to and respond to the governance issues of this council. So where we are today, what are the things that the governance council can and should be doing in your perspective? Should our focus be internal performance? Should it be external performance? What are the needs of the council from an education perspective that governance might respond to? And it feels like September, fresh start, new executive director, new people around the table. A long time since we talked with that kind of a perspective. So I just wanted to open it up and see what the needs of the council are that would guide the governance work.
Thoughts? I would suggest that as we've struggled with role clarity on occasion of in the space around grants, funding, solving issues, that governance of being able to affect the system to be able to make some changes, or is it the council that sort of leads in and decides and grants and funds, and or do we use our support systems, our committee structure, or do we? So I guess as chair, I would say it'd be really great to help us remain clear on what our role is as we get into some of these spaces that clearly have an emotion and an urgency and passionate people wanting to step in, and maybe I'm just speaking for myself, help keep me from, moving us in the wrong direction that moves away from the clarity that we've been able to embrace.
I guess I'm on board with that. We haven't met since April. Are we making work for ourselves? Like you who are running the board, is there something you're not getting? Or like you even, I thought kind of the purpose of the governance council is to say, what is membership? What's the expectation?
Bylaws.
Stuff like that, and like, so we've done a lot of that. Do you feel you don't need to make work if there's none that you need? So is there something you all feel that you need from the governance council to answer more clearly? This is the only other thing on the governance council is like an effective review of if we think the board's performing well or not. But beyond that,
The one thing that
I guess
gets,
I was following
yeah.
you saying like maybe we don't need to do anything if you don't need it.
Yeah, I mean, meeting to meet is always lovely, but yet not. So is there, the first thing that comes to my mind is our role in supporting the outcomes that the CAC is hoping to achieve. And if the CAC is struggling or needs assistance with membership, then is there maybe a way in which we can use the, leverage this body or the governance committee in being able to support them? I don't know, but.
Probably this group though, right?
Well, I'm not sure. I mean, are there outlets, if that's an outlet to be able to talk about composition and be able to talk about assisting the CAC. I wouldn't tell Brad that he needs that, but if he did, that would be something that would come to mind. But I also would ask the committee, if you're struggling for things to talk about, then it's probably time to maybe go ahead and say, maybe we don't need right away.
So I would hope that there's an ongoing plan for annual board evaluation of performance and training the board as to the overall structure of the health council, because government's actually multi-layered, and this is not it. In fact, this is not the majority. And so so over time, this council can be addressed because those two functions don't can be a light meeting process. Sustainability of the good work over the last 2 years is sort of more institutionalized.
Echo those things and just say that ongoing, and it may not be an issue today, but the ongoing thoughtfulness about board composition and makeup and attributes. I can't remember if we're at our full number, board members by bylaw, but if we're not,
We can add.
do we anticipate turnover? What would we do when that happens? So just those things. But that may not be an immediate need. It's just a radar thing.
Linda, is that helpful?
Yes.
Okay, great. And thank you for your leadership in taking that on.
Yeah, I mean, just say thank you, because it speaks to a job well done.
Yeah, right.
Just come and say, hey, we haven't met since April, and we need to know if there's anything you want us to do. Say thank you. I mean, there was a lot of really good work done here. Shoring up some things that we just have. So appreciate it.
And there's some things I know on our list, like succession planning, which is an offshoot, and then onboarding new members.
Right.
Onboarding new board members as well as new governance members.
You bet. Did you have a comment?
Nope.
Okay.
I'll stay and learn more.
Okay, I just wanted to add that this leads into our budget discussion for next year. You know, to say that if we are intentional about training the board, you know, what other types of training do we look at? Do we bring other facilitators in to talk about change models? You know, do we do more cost of care stuff? So I'm throwing it all out there, including DEI work. A main thing that I hear from frontline people is that they all get the DEI training, but their leaders don't. So that's just an opportunity that I'm presenting. That's something that you are interested in.
I think the answer is yes.
Yes. Or maybe everyone's had it. I don't know, like what that assessment is.
Do we have an appetite for, I mean, we have a history of having people come in and talk about different value-based funding or, you know, whatever the different things, you know, payment methodologies or, I think definitely diversity, equity, and inclusion and how we, social justice or any of the pieces of the framework that we're trying to.
What a true community is shared savings model. We have got the whole thing on how money saved in this area was reinvested into this. And it was pretty interesting. I thought that was good. If we do something, should we get a concrete example of what it looks like where it works?
If we actually implement it.
I mean, a lot of the time we spend our time on would be great if the cars went. Yeah, it's great. But how do you make the car? So it'd be cool if someone said, oh, we made the car one.
Yeah, here's how.
Yeah, there's DEI trainings and there's DEI trainings. And so, you know, and I get down to like nitty gritty operational stuff. What happens in Oregon is like, oh, we don't have very many funds, so we have to put it in population centers. And gee, communities like Jefferson County were historically just starved to death and no services. And gee, surprising, it's filled with a bunch of brown people. Oh, it's Oregon. No, we like brown people. We just don't fund anything for them. And we make sure all the funding goes to rich white people. You know, that's what happens and has historically happened over and over and over. And so it's really concrete stuff. And what Oregon does is talk nice and doesn't do anything concrete. And so what I don't want is some talk about saying the right pronouns and more about the right thing. And do we actually follow up and do something different? And it doesn't show up well on a spreadsheet. I mean, in little layer spreadsheets are written Their goals are written. It's complicated, and I would want to see something concrete that actually improves lives of people on the street.
So actionable, you're like traumatized by tea.
I think that these two are kind of saying the same thing, like if we got somebody from King County or Twin Cities to actually end up to come in and talk about some good work that's happening out there.
Yeah,
That's
there's
tangible.
real stuff that's
It's real stuff,
happening.
yeah.
Yeah.
So that's some excitement, Carmen, that's a yes. Okay. Yes.
Actionable, yes.
Actionable,
I'm
yes.
just an old boomer, okay? Come
Yes.
on.
It's okay,
Talking
we'll
about cost of care in that context, or
Yeah.
DEI,
I think
not
both.
loss.
I think it's both. You can actually talk about driving equity forward and lowering the total cost of care and lifting up patient population health outcomes.
Fair.
You can do it all. I agree. I think
Yes, on the DEI discussions, because I'm not involved as much in prosecuting, maybe saying, it feels just personally to me that the initial DEI trainings were sort of break this up into this issue. And some people chose to dive in deep and learn. What I'm finding now is the greatest growth for me is just in interactions with staff. Whoever, where I find myself, oh, that's a whole area, you know, so if we were to do some more work about it, or I think it would be not just high level.
Okay.
We would need to have some
Exercise. Okay.
application.
Okay.
And in doing that, we can be more sensitive and model for staff in the front line. But they're not getting, it's, for me, it's like time to roll up our sleeves and get in it.
Yeah.
Not just learn about it.
But it also, what I also hear is an appetite of, we want to stay ahead of what we're doing. We want to stay excited about the work, although it's difficult and it's sometimes not as, not making as much of a move forward as we might have hoped. But keeping us in this relevancy of what we can change, and that we used to celebrate a lot of what we had done, and maybe there were moments where we were sort of like, yeah, but that was a little while ago. What have we done today? I think it gives us an opportunity to be reinvigorated about the work that we get to do, and how others are leading the way, and we can learn from some of their efforts as well. Does that give you what you need? Okay.
I don't know, I just learned this that all Oregon public K-12 are launching mandated education on the original people of Oregon, the Oregon tribes. And so a team of people have been working on that over the last several years to develop the K-12 curriculum. I myself am super curious about how to see that curriculum and to see how it builds on a K-12. So that to me would be super cool, because I bet none of us, except for you, have seen that curriculum and how that affects us in our unique privilege and opportunity to serve our original people in our region. So I thought that was cool. I heard that earlier this week.
I guess my question too is, has there ever been tribal representation at this board or other diverse?
No, it's been reached out. This has traditionally been a live meeting event, so that is an hour and a half from Warm Springs one way, and the relevancy to Viking Warm Springs has been hard to see. So getting some
from the lunch place to show up to a live meeting here is difficult. And I think there's been good efforts to reach out to Warm Springs for a specific source and through going up. So then I think the opportunity is there opportunity with the virtual world now to bridge that. So
It's always been a gap. And I think also CAC is an important place. It just here, I don't think we need representation throughout our committee structure and throughout city council. So, yeah, I agree.
I mean, operational, I think the civic source, you guys can go back there and try to develop relationships. But having someone on this council
And I think it's a good time to really do another outreach because we did move our meetings around a fair amount, meeting in Madras, the hospital, meeting in different places. But I think even where are we meeting? Is that going to support individuals wanting to participate? Is that a safe environment that also is a welcome environment for individuals too? So I think it's a good time for us to be looking at all of that.
I think one of the learnings coming back in, however that's been for every organization, is that the part in-person, part virtual meeting is the worst. We could ask these people today how much they heard, and they would say 20. Last time I was doing that, it was 20%. So you just tune out. And so as good as it is to move around, our obligation is to be in a site where they can hear everybody.
Excellent.
So we have to really figure that out if we're going to do this half-half. It's great to do, and we tout the virtues of it because it can expand our reach and expand the accessibility of a meeting, but it's not accessible.
Right.
And that's not a criticism, it's just one of those moments of like, because nobody projects like they're mad at their children. We all start that way, and then we stop.
Yeah,
right?
true.
And,
yeah, and I know internally at Westcare, we had to just recently, we got so frustrated with that problem.
Yeah.
Invest in our audio system so that we can have.
Right. Lots of places have. We've got it to the point where if you're in the room, if you rustle a piece of paper, people there go like this. So it has other issues, but you have to be in a place where when Megan talks, you can hear.
What we will do with a lot of our meetings is either they're all virtual or they're in person. We'll do 3 or 4 in person a year and all the rest are virtual. If you're all there on Zoom, it's a whole lot better than this.
Yeah, it is.
Okay.
This is actually the worst. As
Yeah.
good as it is to be here, it is the worst form for comprehensive participation. It just is.
Brad, you want to share out loud what you just said?
Can I get an amen? Is that what you said?
No, hold on.
You're super loud when the people on the Zoom talk, because I've got it up to 100%. I was just letting you know that I've heard about 80%, I would say. Mostly I can hear everything, but there's definitely certain people in certain moments where it's, the volume just drops and can't really follow what's going on.
For example, in this room here right now, I can't hear anything.
Right.
Literally cannot, okay, I can hear you because I can hear Dan, but I can't hear you. And it's because, I should have gone up and moved over there, but it's in the middle. This is, and you can't see the screen because it's moving. And I
Yeah.
don't criticism because
No, but if we can't get access right, really, I mean, I think these are really important things to point out. So I appreciate that, yes. Okay. So let's work on that a bit more in terms of our calendar. Yeah. Because, and the other side is, communities, Lafayette will say, well, we want you to come to Lafayette, but if it's not conducive to a successful meeting, where is the value in being in the community? I other than saying you were in the community. So maybe there's a conversation of, do we support a community event? Do we go to the community in a different way as board members instead of just posting a meeting and checking the box and saying that we were in a community? So anyway, we can chat about that. We can, yeah, I bet we can.
Just be loud for
We have to rent it, no, but there, I mean, it might be wise to do a study for the meetings that we want to do virtual plus in person. Who are the either organizations or partners that have the wired conference room, right? And Brad, I'm glad it was 80%. I can't remember where y'all were last month, but I was just 20%.
Yeah.
Even after.
And that was tough, and facilitating then makes it, because I don't wanna, state for you what you're saying, because then that feels awkward too, because, so I completely get it. Yeah, and I'm hard of hearing, and so I typically speak a little loud, and if you're on the phone with me, I really yell, because I use the phone on my ear that I can't hear very well, so, so I'm a real mixed bag, so, but with that, I think we can, we all play to our strengths, and maybe there's an opportunity here for us to refine our process, so thanks for bringing that forward. Okay, anything else for the council? All right, well, it's been fun, we're adjourned. Thank you. Bye, Brad. Bye, Divya, bye, Dustin, bye, Renee, bye, Jeff.
Bye, everyone.